Okay, so overall, it's a great pleasure to be at least online on the Saudi Arabian BMT, EBMT Highlights 2023. I really would like to thank Ahmed Alaska for inviting me and also Anna Zoreda for inviting me. So for this nice, long-lasting collaboration between the Saudi Arabian bone marrow transplantation unit and society and the EBMT society. So for me, it's a great pleasure to give you an update about the latest advance in myelofibrosis, especially regarding the curative treatment of allogeneic stem cell transplantation. So these are my disclosure for this presentation. So as you know, there are several hallmarks of the disease myeloproliferative neoplasia. So this is myelofibrosis, and one is a huge spleen, and the other is a severe myelofibrosis, but also osteosclerosis, as you can see, which historically was a major issues for transplanters because huge spleen and also the severe osteomyelofibrosis was something which concerned the transplanters to do hematopoietic stem cell transplantation in this otherwise malignant and non-curable disease, because they were all afraid of engraftment. And still today, the engraftment still is, in contrast to other hematological disease, more frequently observed in myelofibrosis. But in the last years, let's say 10, 20 years, several approaches has been developed to facilitate this curative treatment in myelofibrosis. So as you can see in this example of bone marrow histology, you can see the severe fibrosis, you can see the osteosclerosis here, and you can see this malignant megakaryocytes, and you can see reduced hematopoiesis. So this was the reason why this disease has not been transplanted for many, many years. And one of the first reports about stem cell transplantation was just 20 years ago when the French Society of Stem Cell Transplantation, together with Fred Hutchinson Cancer Center, the Italian, and the EBMT, just reported only 55 patients, very young patients with a median age of 42, that this kind of treatment can be curative, as you can see, in about 50% of the patients by using here at this time point myeloablative conditioning. But also at this time point, you can see that unmanipulated HLA matched transplantation resulted in a better outcome than those who were T-cell depleted or had received an alternative donor. However, when we look to the registry and the development of myelofibrosis transplantation in EBMT, but also in CIBMTR, so you can see until 2000, 2002, 2003, you can see less than 50 patients were transplanted per year in the entire European EBMT community. And you can see also that the median age of the patient was about 50 or a bit lower than 50 years of age, which is actually not the current median age at diagnosis for myelofibrosis, which is 65 to 70. So then in the EBMT, we developed in the late 90s a prospective phase 2 study investigating the reduced intensity fludarabine regimen followed by allogeneic stem cell transplantation, either from HLA identical sibling or from matched unrelated donor. And in some patients, also mismatched unrelated donors had been performed. And we included more than 100 patients. The median age is now older. It was 55 years of age. And you can nicely see that about in younger patients, about 80% could be cured. So age was a significant factor, but also the donor. So HLA identical matched sibling, but also matched unrelated donor has also in survival about 80%, which was worse for those who had only and mismatched unrelated donors. And also the disease of the myelofibrosis at time of transplantation had also some impact on the outcome. However, at this time, the score was not the updated score according DIPS, it was the old Lille score. However, this prospective EBMT study has really moved the field forward because it could not only show that you can induce molecular remission by allogeneic stem cell transplantation, but also you can see a very rapid decrease in the bone marrow fibrosis, as you can see in this example. So on the left-hand side, you have seen this already. You have seen the severe fibrosis, osteosclerosis, and just 100 days after transplantation, you can see a complete resolution of the bone marrow fibrosis, a nearly complete resolution of osteosclerosis, but you can see there is some osteosclerosis, But you can also see a nice hematopoiesis without any fibrosis and a completely disappearance of this atypical megakaryocyte. So this then led to a rapid increase in using allogeneic stem cell transplantation, mainly with reduced intensity conditioning in Europe, but also worldwide. And nowadays we have about 500 patients per year who are receiving allogeneic stem cell transplantation for myelofibrosis. And the other development which we can see is that the increasing age. So nowadays the median nearly 60 years of age for patients who are receiving allogeneic stem cell transplantation, mainly by reduced intensity conditioning regimen. So you can see by this development, a rapid increase in this treatment approach has been observed in our history. So coming back to about the time point and which should be transplanted. So you know that the myeloproliferative neoplasia are divided into essential thrombocythemia, polycythemia vera, and both of these can transform into post-ET, post-PV myelofibrosis in about 10%. And this disease can directly devolve into plastic phase, more frequently in P vera rather than in ET. And also myelofibrosis, whether this is post-ET or post-PV myelofibrosis or primary myelofibrosis, can also transform in about 20 to 25% into plastic phase. And I talk briefly about plastic phase, but then the major indication is myelofibrosis, primary or post-ET, while ET and P vera has a quite good expectancy of life. So currently there is no indication for doing allogeneic stem cell transplantation in ET or P vera. So I start with the plastic phase. So plastic phase usually is associated with poor outcome in non-transplant setting. And interestingly, if we adjust secondary myeloid leukemia, this is data from the EBMT, into the underlying disease, you can nicely see, even if you adjust according age, cytogenetic, and other risk factors, that outcome of secondary leukemia derived from MDS is significantly better than those who were transformed from CMML, and the worst outcome were noted for patients who were transformed or transplanted for secondary leukemia after MPN treatment. And this is mainly due by a higher risk of relapse rather than a higher non-relapse mortality. So some data about the transplantation in plastic phase has been reported. So the early phase from EBMT, you can see resulted at least in a survival, overall survival out 30% long-term. And the major risk factor was being in complete remission at time of transplantation. More recently, EBMT had updated this with a higher number of patients, but the results were pretty much the same. About 30% can be salvaged by allogeneic stem cell transplantation in plastic phase. And also here confirmed the early EBMT data that being in CR resulted in a significant better outcome than those who received no CR and then proceed to allogeneic stem cell transplantation. So regarding overall survival, about 20% has been reported by CR and EBMTR as well. However, here the achievement of complete remission was not so important rather than cytogenetic features, mainly if patient harboring P53 mutation, which resulted in a pretty poor outcome. Interestingly, accelerate phase. So accelerate phase in myelofibrosis is defined with blast count between 10 and 90% in peripheral blood or bone marrow. In this large cohort, which we did with international partners involving more than 300 patients, we could find in 35 so-called accelerate phases, means patients who underwent allogeneic stem cell transplantation with a blast count in peripheral blood between 10 and 19%. So interestingly, if you see the different results, there was no major difference in overall and relapse-free survival in patients who received stem cell transplantation for accelerate phase without any induction therapy before transplantation. There was a slightly higher risk of relapse, but this did not result in a poorer outcome, probably because the risk of non-relapse mortality was actually a bit lower in those patients who received allogeneic stem cell transplantation for accelerate phase. So I come now to the more chronic phase. So this is a chronic phase, is a myelofibrosis, the primary or post-ET myelofibrosis. And I will focus in the next 20 minutes about the patient selection, the best timing, but also how we can improve outcome after allogeneic stem cell transplantation. So here you can see what we talk about primary myelofibrosis. So in contrast to ET and PVERA, so this is the worst outcome. So the median survival, even if it had improved over the more recent year, the median survival for those patients is only 6.5 years. But you can see the disease course is quite heterogeneous. So we have patients, so about 20% of the patients who died within the first 2 years, but we have also about 20% of the patients who are still alive after 10 or even 15 years. So here it's very important to select patient, and for this reason, several so-called disease-specific risk scores has been developed, and one of the prominent is the so-called dynamic international prognostic scoring system, which can be used at every time point during the course of the disease and include age, constitution symptoms, anemia, leukocytosis, and peripheral blast count. You can see you have points, and then you can build a score between 0, intermediate 1, intermediate 2, and high. And you can see the survival differs substantially according to the different risk group as defined here by this DIP score. So more recently, other molecular genetic has been come into the field of myeloid malignancy and also in myelofibrosis. And there are some high-risk mutations, especially A6L1, ECH2, but also IDH1 and IDH2, which is part of this new classification, which is called molecular IPSS 70. So 70 means these are potential patients who can be treated by allogeneic stem cell transplantation. And with this score, you can also divide low risk, intermediate, and high risk. And you can see the median survival for low-risk patients is more than 25 years, for intermediate about 7.1 years, but for those patients with high-risk features, it's only 2.3 years. So that's because no randomized study existed, and it's very problematic to perform randomized studies if there is no other, let's say, curative treatment approach. So there are several methods to compare transplant to a non-transplant approach. This was done by EBMT study or by studies from the EBMT comparing transplant to non-transplant by so-called left truncation decision model. This is a hypothetical model, but it shows you that for low-risk patients, the non-transplant approach is more of benefit significantly, while for intermediate 2 and high risk, there is a benefit for going immediately to allogeneic stem cell transplantation. While this is not so clear for intermediate 1 patient, you can see an earlier, higher non-relapse mortality, but you have also some curative approach. So here, after 10, 15 years, the curve is crossed. So currently, no clear indication for allogeneic stem cell transplantation for intermediate 1. So CIBMTR reported similar results, even if the statistical model they used were a bit different, but they compared also non-transplant to transplant approach. So here in A, you can see the low-risk group, the intermediate 1, the intermediate 2, and high-risk group. And you can see the curves always cross, but they cross at different times. So for low risk, you can see the curve cross after 10 years. Here in intermediate 1, a bit earlier than in the EBMT, about 7 years. But you can see an early cross of the curves for intermediate and high risk. So CIBMTR resulted, so confirmed, or let's say they proposed also indication, a clear indication for myelofibrosis in intermediate 2 and high risk, and also a relevant the indication in Europe in 2020, and you can see for DIPS intermediate 2 and high risk, there is a clear recommendation for allogeneic stem cell transplantation, either for matched sibling transplantation, but also for unrelated transplantation, but also here for mismatched unrelated transplantation. But I will come to this a bit later. So, however, when we see all the disease-specific risk scores, we ask a question whether the outcome of transplantation is also good if you use these different risk scores in the transplant setting. So we try to develop the so-called transplant score, to show whether we have other risk factors for allogeneic stem cell transplantation than for non-transplant approach. And in this more than 360 patients where we had also a complete molecular workup, we could find the leukocyte count, the Karnofsky index, the CAL-MIBL unmutated genotype, the platelet count here, the cutoff was 150s, the age cutoff was 50, 70 years. Also, HLA mismatch unrelated was significantly a poor outcome, or for the molecular mutation, it was the A6L1 mutation, which has a hazard ratio of 1.42. So interestingly, what you can see in this multivariate analysis regarding outcome after transplantation, so neither anemia nor the number of blasts were significantly for outcome after stem cell transplantation. So patient with a hazard ratio more than 2 received 2 points, the others received only 1 point. So we ended up with a score about low, intermediate, high, and very high. And you can see this translated into a very nice discrimination in overall survival. So low-risk patient had an overall survival about at 5 years of 90%, and then a relative low non-relapse mortality. However, if you have very high score, so let's say high or even very high, then the overall survival after 5 years decreased to 5 or even only 34%, with an increase in non-relapse mortality up to 50%. So this might help us. Here you can see the corresponding figures. So this is the cohort, then you see the validation cohort, and you can see this slight discrimination between the different risk scores regarding outcome transplantation. And here you can really counsel a patient probably what is the expected outcome after allogeneic stem cell transplantation, or what is the expected risk of non-relapse mortality if patients undergo allogeneic stem cell transplantation. So this has also clinical implications. So in our daily practice, when we see patients with myelofibrosis and they came to us with intermediate 1, intermediate 2, and high risk, and just asking for the indication for transplantation, especially for the intermediate 1 group, where there is actually no clear indication, but we should counsel the patient more on a personal basis. So here you can see in this slide, this is a correlation between transplant risk scores and the DIP score. So patient with DIP score intermediate 1, let's say intermediate 1, this is the yellow one, you can see that about 22 patients who are intermediate 1 have a low transplant risk. So that means these patients have an outcome of about 90% overall survival. So particular this patient, if this patient, we counsel them that the outcome of transplantation will be pretty good. And for us, this might be a patient group, especially if they are younger, to go also for allogeneic cell transplantation if they are only in intermediate risk 1 group. However, we have also 20% of the patients who have a high risk according to the transplant score, and these patients have a lower probability of survival after allogeneic stem cell transplantation and have a higher risk of non-relapse mortality. So these were patients where we certainly would not recommend allogeneic stem cell transplantation in a stage of intermediate 1. So this might help us to guide patients, to counsel patient probably, and then have a more personal approach in allogeneic stem cell transplantation. So we further try to develop this to further go more into personal medicine, and we look for dedicated mutations. And we recently looked for this P53 mutation, which is very unfavorable, especially for AML, but also reported for MDS, but only very few data were available for myelofibrosis. So we checked more than 360 patients for P53 allelic status. You can see, fortunately, the majority has no P53 mutations. And a very small group here, 19, has a so-called single hit mutations, while 30 patients from this large cohort, about 10%, had what we called multi-hit P53. That means they have 2 different mutations in P53, or they have a high allele frequency, more than 50%, or they have, beside this P53, also a complex karyotype. And these patients are characteristic usually by a low hemoglobin and platelet count, And when we see the outcome of the allogeneic stem cell transplantation on the right-hand side, you can see you can still cure patients with this multi-hit P53 mutation. However, the likelihood of being cured is only 30% and is significantly lower than for the wild type and for the single hit mutation. And interestingly, the single hit mutation did not differ significantly from those who have wild type. So if you check for P53, the recommendation is also to see whether this is a multi-hit mutation, because only these patients have a poor outcome. And this is mainly related to a higher risk of relapse, which we observed after allogeneic stem cell transplantation. And this patient group is also very interesting, often relapsed pretty fast, and they relapsed not very rarely with secondary acute leukemia. So more recently, also the CIBMTR developed a transplant score to counsel patient probably. However, they hadn't had any molecular data, so they included age, the cutoff of 50 years, hemoglobin here in their cohort. In their cohort, it was significant, and the donor, they found similar, that the donor is only partially matched, unrelated. They have a higher risk of non-relapse mortality. So, and this was just recently published, is on online only. You can see they separate also 3 different groups. However, the discrimination, so the EBMT, they provided some validation cohort, the discrimination was not so significant as we have seen for the transplant-specific cohort. So lastly, I will just give you some ideas how we can improve outcome after allogeneic stem cell transplantation. So you know, the stem cell procedure is not only the conditioning and the stem cell infusion. So it started already with the pre-treatment. This is important in leukemia patient, but becomes also more important in MPN and MDS, conditioning, the GVHD prophylaxis, and relapse prevention. And we have several options to intervene in these different steps. So when we start in the pre-treatment, so it's nowadays recommended, especially in patients with huge spleen and constitutional symptoms, to start with a JAK inhibitor. So for instance, ruxolitinib prior to allogeneic stem cell transplantation. And usually a couple of weeks is enough to shrink the spleen and improve constitutional symptoms. In this large EBMT study, interesting, we could observe, or we could see that patients who received ruxolitinib and then received stem cell transplantation, while they are still responding to ruxolitinib, they have a significant lower risk of relapse. This is the green right here, resulting in a significant better event-free survival, and also a trend for overall survival. However, the follow-up was quite short. While patients who did not receive ruxo had similar outcome than those who received ruxo but failed to ruxo and then received allogeneic stem cell transplantation, as you can see here in the red and in the blue curve. So suggesting in this retrospective but large EBMT study that if you have a patient who had indication for transplantation and has a huge spleen and constitutional symptoms, and you start ruxolitinib, you should not wait until patient is losing response to ruxolitinib, rather than to proceed immediately if patient respond best to allogeneic stem cell transplantation. So the intensity of the conditioning is always a question of debate. However, largely this is a larger study from EBMT showing that reduced intensity and myeloablative regimen resulted actually in similar event-free, relapse-free, and overall survival. And even another study which we did using molecular marker to see whether maybe high-risk cytogenetic, high-risk molecular genetic might benefit from a more intensive regimen. So you can see here all the different factors we analyzed, and at the end there was no significant factor which was really in favor for myeloablative or was in favor for reduced intensity. So thus, at least in our institution, we do only reduced intensity conditioning, also in younger patients. So the impact of the donor is, I mentioned this already, several groups has shown this. This is a combined Seattle-Hamburg approach in more than 380 patients. And clearly you can see matched sibling transplantation is still the donor of choice if available, followed by complete matched unrelated, and then followed by mismatch unrelated. or more recently, some data about haplotransplantation. They are coming more and more haplotransplantation. This is one study from the EBMT, published just a couple of years ago, but there come also other studies from CIBMTR, from single center in Italy. They show all the same, so that the risk of non-relapse mortality is in general a bit higher. The risk of non-relapse mortality by graft failure is higher. So the overall survival is not as good as for a completely matched donor. But this is a learning curve, so we hope that with the PTCy approach, but most of these patients were treated with PTCy, that maybe in the future the learning curve will improve the results, so that allogeneic stem cell transplantation with haplo can achieve similar good results as with completely matched donors. So very important, and lastly in my presentation, is the so-called prevention of relapse. And in this disease, we have so-called driver mutation, with this JAK2, calreticulin, or MIPL. So in about 90% of the patients with myelofibrosis, you have at least one of these mutations. And you can monitor this with PCR technique. So in this 90% of the patients post-transplant. And here we analyzed this mutation load at day 100, on day 180. And in both time points, you can see patients who are still positive here by day 180. They have then a significantly higher risk of a clinical or hematological relapse during follow-up than those patients who were at this time point, 180 days post-transplant, MAD negative, detected by a sensitive PCR with CAL, MIPL, or JAK. And this is important for your follow-up, because this is a disease, even if they relapse, the relapse is not so, let's say, so rapidly as you see in AML or in other disease. So you have time to intervene. And what we did in the last 20 years, actually, so we monitor this patient closely, if possible, and we call this then, if they were negative, becomes then positive, we call it molecular relapse. So this has to be determined by twice consecutive samples. Otherwise, they still have a good blood count, and they have otherwise no signs of myelofibrosis. And we have also 20 patients who had received a hematological relapse, so with bone marrow fibrosis and the typical signs in the peripheral blood. So all these patients achieved donor lymphocytes infusion in an escalating fashion. So if they received a second transplant, they were censored. So what you can see, that about nearly 90% of these patients who were detected molecular relapse and received DLI could achieve again a molecular relapse. And this could be achieved also in 60% in those patients with hematological relapse. However, the numbers of DLI to achieve this molecular relapse was significant, was a bit, not significant, was lower in the molecular arm. And very interesting, what you can see, there were some GVHD, but very limited. Interestingly, and this is here, I want to show you on here. So that is patients, there are significant, so half of the patient, which is not here on this slide, unfortunately. Let's see whether it's on the next one. No. There are about 40% of the patients who could achieve the molecular remission without GVHD. So you can target the GVL or GV myelofibrosis effect without a graft versus host disease. So the outcome is quite favorable. So here you can see those patients who received, who achieved the molecular remission. So you can see the long-term run is about here after 15 years. So still 75% of the patients are still alive, while those who did not achieve the molecular remission, so who were treated for hematological relapse, you can see there is also a chance for long-term survival, about 30%. However, this was less than if you intervene in a status of molecular relapse. However, if the patient achieved a molecular relapse independent of the molecular or hematological relapse, you can see here, and then the outcome is always very favorable. However, all this data suggested that a monitoring of this patient post-transplant should be done regularly, also after 5 or 6 years, because late relapse can occur. And then an early intervention with donor lymphocyte infusion is justified in molecular relapse. And preferentially, you should not wait until patient has a complete hematological relapse. And with this slide, I want to end. So you have different options to intervene in the pre-treatment, in the conditioning I mentioned, the selection of the donor, the GVHD prophylaxis, and most importantly, this harnessing of the immuno effect post-transplantation by monitoring with molecular marker and then discontinue CNI early on and start donor lymphocyte infusion. And to the lack of time, I did not mention, but also those patients who did not respond to donor lymphocyte infusion with the second allogeneic stem cell transplantation in selected patients at 30 to 40% long-term survival can be achieved. So I would like to thank all the members of my department from the European Leukemia Net, from the different, from the Chronic Malignancy Working Party, but also on the other partners who are working in this field with us to improve outcome after allogeneic stem cell transplantation for myelofibrosis. So I'd like to thank you for your attention, and I'm open for questions. Thank you very much.